Is myasthenia, which in a way probably ought to have preceded the earlier talk because it introduces you to some of the concepts that have been so important. So basically we're talking about antibodies to synaptic proteins, which you've already heard about a bit this morning. But of course this is a neuromuscular junction with the nerve and the muscle. And just to remind you that the acetylcholine receptors are on the surface of the junction between the nerve terminal and the muscle surface, and the receptors are very clustered, as you'll hear a little bit more about later. And of course acetylcholine is a transmitter that binds to these receptors, activates sodium channels, and that leads to the compound muscle action potential and contraction. So that's the normal neuromuscular junction. Now in myasthenia gravis, as I'm sure you're very well aware, there are antibodies to acetylcholine receptors. We measure them usually with a precipitation assay, where the receptor, which is extracted from human cell lines, is labeled with a radioactive toxin from the snake. So tropical medicine has been very important in this field in helping us to identify the right toxins to use in our assays. And in fact, the toxin binds to two sites on the acetylcholine receptor and makes this a radioactive molecule, and you can precipitate the radioactivity with the patient's antibodies. And this is the sort of levels you get, and this is actually a log plot, so you can see they're very variable, and some patients are always negative. And of course that intrigued us right from the beginning. But first of all, something about the positive patients. So what do the antibodies do in myasthenia? Well, they do three things. One, some of them block the function of the acetylcholine receptor by preventing acetylcholine binding. Those antibodies are actually not very common. Much more frequently, because there are two binding sites for the antibodies on the receptor, and antibodies have two arms, generally speaking, the antibodies cross-link the acetylcholine receptors in the membrane, and that leads to internalization and breakdown of the receptors. So that leads to loss of receptors. But at the same time, another probably more important mechanism is that many of the antibodies, because they cross-link, they can activate complement. That leads to the membrane attack complex, which breaks down the muscle membrane, releases acetylcholine receptors, and destroys the morphology of the junction. So that's probably the most important mechanism. And these antibodies are usually the IgG1 and 3 antibodies, which are the ones that activate complement. So I suspect that mechanism predominates. So what happens at the neuromuscular junction in myasthenia? The antibodies come and they lead to loss of receptors and also morphological damage to the junction itself. And there are other things that happen, but I won't go into that today. So how common is this disease? Well, when we started working back in the 1970s on myasthenia, it was not considered very common, and it was mostly thought to be young women, sometimes with thymic hyperplasia, and sometimes with thymoma. Thymoma patients tending to be a little bit older, and sometimes males as well, or females. But now we know that this is actually a much more common disease than we thought, and if you do a survey, as this was done some years ago now, of the patients being identified in the UK, you see that there's at least two main groups. There's the young women in pink, with less frequent males in this age range, but as you get older, it becomes more and more frequent, this disease, and in fact males then predominate over females, despite the fact that male survival to that age is actually lower than female. So relatively speaking, males are actually about twice as likely to get this disease as an older person. And our data, which was done in collaboration with Peter Rothwell, who's very much a statistician and clinical researcher, indicated quite clearly that there was underdiagnosis and misdiagnosis of patients in this older group. So if you're not identifying patients with myasthenia in the elderly, you ought to start looking, because they're probably there. When you look at the actual level of antibodies, which is done fairly quantitatively in most laboratories, you see that there's a problem with the children who clearly weren't very frequent, they tend to have lower antibodies. And in fact, very few of them have really high antibodies. And this, of course, is always going to make diagnosis a little bit more difficult if you're not thinking about it. So there's a recent chapter which is going to come out fairly soon in the Handbook of Pediatric Neurology, which is part of this series. And it's on autoimmune childhood myasthenia, essentially from my two pediatric neurology colleagues in England. And I thought I'd just mention some of the reviews that they've made. So for one thing, there's clinical subtypes of myasthenia. There's juvenile myasthenia, juvenile ocular myasthenia, often without antibodies to the AChR. Juvenile myasthenia with muscle-specific kinase antibodies, I'll mention that very briefly. And there's transient neonatal myasthenia that you have to just be aware of if you're a neonatologist. And then there's prenatal myasthenia. Oops, that's clever. Never done that before. Is that? It's okay on your screen. And there's prenatal myasthenia, including arthrogryposis. And I just mentioned these very, very briefly. I don't know quite what's happened. Something's happened. Okay. So typically, myasthenia is just like it is in adults: generalized fatigue or weakness, often asymmetrical, ophthalmoplegia, ptosis, extraocular. Page up. Extraocular myasthenia presenting in about 20% of children as the first episode. Most develop limb and bulbar weakness subsequently. Ptosis during the swallowing difficulties are very obvious. Feeding difficulties, particularly choking episodes in children, are very important, and of course aspiration. And the children may ask to be carried, falls can be frequent, and there's difficulty climbing stairs, and therefore they have problems at school. And I think that's probably the feature which stands out in these patients, these children. And of course there's a risk of chest infections. So ocular myasthenia, about 25% of patients with myasthenia in childhood. It's obviously restricted to the ocular muscles, and it's probably much more common in oriental populations, as we and others have shown. And that's something which does raise the issue of ethnicity and the relationship with myasthenia. Altogether, in childhood generalized myasthenia, you can see on the right, those are features that have already been mentioned. But in real infancy, of course, you can get hypotonia, muscle weakness, a weak cry, and feeding difficulties, which may not immediately bring to mind this diagnosis. And you can get children presenting very early with this disease. The differential diagnosis, the first one you have to think about once you've decided it's myasthenia is it autoimmune or is it congenital? Because there are genetic forms of myasthenia, which I'm going to list in a moment, which are relatively common in this age group, because the autoimmune myasthenia is not very common, so the genetic form tends to be something you really must think about. But it's probably less common than the autoimmune form. And of course there's mitochondrial diseases, myopathies, neurotoxins like botulism, Guillain-Barré syndrome, and various other conditions, which in some cases can mimic the symptoms of myasthenia. There's a comparison in a review by Finnis and Jayawant, which came out a year ago, which compares pre-pubertal and pubertal myasthenia, and also compares them with the adult from the literature. And it's quite interesting that if you take the pre-pubertal patients, so you see here these pre-pubertal patients are not very different in general from the adult and the pubertal patients. But there does seem to be a proportion of patients in the Caucasians and particularly in the Chinese who fall into this category. And spontaneous remission seems to be quite high in these children. And I don't know how well that's been evaluated. It certainly was the case in the Chinese patients that we looked at, and it may also be quite common in other populations. So I mentioned that you mustn't consider that all neuromuscular junction disorders are autoimmune. And here's a list of the various congenital forms, and obviously you don't want to memorize this, but it just gives you an idea of the different forms of genetic disorders affecting the neuromuscular junction, which are caused by mutations in very specific proteins, of which the acetylcholine receptor, which is this gene here, is by far the most frequent. But this gene here, which we'll mention in a moment, is for rapsin, which is also very important. And then there's a protein called DOX7, I won't mention otherwise, called Q, another type of acetylcholine receptor mutation, etc. Lots of different mutations, but actually all, to some extent, presenting in a similar manner, and which can be confused with the autoimmune form. And of course, these diseases don't respond to immunotherapies because they are genetic. But there are some pharmacological treatments which are proven to be quite useful in these patients, and they're sometimes quite interesting. For instance, salbutamol has been shown to be useful in some of these patients, for no clear reason. But I want to talk now just briefly about the patients who are negative with the conventional acetylcholine receptor antibody test, which is in fact commercially available in various forms. So, rapsin is this protein which can be genetically altered in myasthenia in congenital myasthenic patients. And the reason why it's so important is because it clusters the acetylcholine receptors. And without rapsin, your acetylcholine receptors will just diffuse away along the membrane and will not be present at the neuromuscular junction. So it's a very important protein for the function. So we thought that perhaps there might be some patients with myasthenia who had antibodies that bound to the acetylcholine receptors, but bound rather weakly and with one arm at a time. So if you only bind with one arm, that's clearly less useful than binding with two arms, where you can grip something very intensely. So what we did was to express in this cell line the acetylcholine receptor, which is shown here, with rapsin, which we made green, and then we said, can we now detect the antibodies binding to the acetylcholine receptor, because they'll be able to bind with two arms at once. And rather like I showed you earlier this morning, we detected the binding with a second antibody, which was red fluorescent. And what we found was in this middle column really, so here are the green cells, and here are little clusters of receptors and rapsin. Rapsin is the green, in fact, but the receptors are sitting on top of the membrane where the rapsin is clustered. And when we put this patient's antibodies on, this patient had never been positive, he was actually a doctor, 40-year-old male doctor. His antibodies now bind really quite strongly to the clusters of acetylcholine receptors, showing that this is definitely an improvement on the previous assays for this antibody. And we found these in about 50% of patients who had been consistently negative in the past. So that was one minor development in the techniques. And the other, of course, was this protein. This is muscle-specific kinase, which was identified by some basic biologists in the 1990s and has proved to be a very interesting molecule in the neuromuscular junction because it's absolutely essential for the whole process of this rapsin clustering of the acetylcholine receptors. So if you take a mouse and you knock out this protein, then you don't get clustered receptors and the mice die at birth because they can't move. So MuSK is a proper antigen, a new antigen, or relatively new antigen at the neuromuscular junction. It's a muscle-specific kinase. It's restricted to the neuromuscular junction, and it's very important during development and for maintenance of the neuromuscular junction in adult life. And there's a lot of very basic and very beautiful work done on this protein. So we started measuring antibodies to MuSK by making it radioactive and asking if the patients had antibodies that cooled it down. And you can see that about half the patients who were previously negative have antibodies to MuSK, and the other half don't, and we still call those seronegative myasthenia gravis. But these patients, the ones with the AChR antibodies, do not have MuSK antibodies in our hands. They're two separate diseases now. And here's a typical patient, and in fact this was our sort of index case, because she was aged 2 years, and as you can see, nice little girl, nice smile, eyes wide open. But by 3 years old, she developed myasthenia, and it was bad, and she was very lacking in expression, but she was also weak physically. I first saw her in a wheelchair, and it was only really when they stepped up immunosuppression that she became physically fine, except for her bulbar functions, which were particularly affected, as they often are in this form of myasthenia. And I'll just show you a little bit of this. So there's no sound, but you can see her eyes are quite weak, and her ptosis is evident. She's been asked to smile. That's the best she can do. And she has very severe facial and particularly mouth involvement. And you'll see in a moment that her tongue is very atrophied. And as a result of this, she had terrible dysarthria. And I always think that in a young girl of this age, she was a teenager at this stage, that to not be able to smile and talk to your friends must be extremely difficult. For instance, she couldn't use a mobile phone because her voice was just indistinguishable. And you see that she's got complete palatal paralysis, and they ask her to say, "Ah." But funny enough, chewing was okay, and the masseter muscle seems to be quite well preserved in this disease. So she's a very nice young woman. She's now actually almost 30, and she's had a baby. And what made the difference, although she still looks very similar, is that she had rituximab about 6 or 7 years ago. And just a couple of injections of that has seemed to have made really some difference. And it's remarkable that rituximab seems to work quite well in the MuSK antibody patients, although it often doesn't seem to work much in the acetylcholine receptor antibody patients. That's an intriguing difference, as shown by others. So we've recently done a population study of childhood forms of myasthenia, and that was with these colleagues, particularly Jeremy Carr and Sandy Jarrett, both pediatric neurologists. And it's over 5 years, and we identified 102 children in the UK with a female to male ratio of 3:1, age 1 to 17, and these were the ones that did have the AChR antibodies. So the annual incidence of all MuSK antibodies, the annual incidence of AChR positive myasthenia was about 1 to 2 per million in children, and the mean was 1.5, so not very large numbers. So if you look at the ages at onset, females still predominate, but there are males and females at every age, and these were not neonatal ones, they were between 1 and 5 mostly. And there's still the beginning of a dominance of older, post-pubertal, probably, patients. And in the MuSK patients, there were very few, and mostly women, mostly young girls, which is what you would expect, and only 1 to 2 a year compared with 20 per year of the AChR antibodies. So this is going to be a very small number in most countries. But one of the points about MuSK antibodies, which is just intriguing, is that it seems to have a geographical distribution. And in fact, if you look at antibodies to MuSK in different populations, you find that the farther north you go, the less MuSK antibodies you get. And then as you go further south towards the Mediterranean, it rises. And thereafter, it seems to go down, but there's really not that much data. And some of it comes from eastern countries, which may have completely different etiologies anyway. But I thought it was amusing to say where you are, and as far as I can make out, you're about 25 degrees north of the equator, and you probably should be somewhere on that line, if my calculations are correct. And it won't be very many patients. But if you see one, it's a very striking disease, and it can be rather difficult to treat. In fact, that's in a way shown here, because if you take typical AChR antibodies and you ask what's the severity, it tends to be relatively mild in many patients and only severe in a few, whereas the MuSK antibody patients tend to be more severe and often this very bulbar involvement. The ones without either antibody also seem to be skewed much more to the lower grades of severity. Just lastly, what about neonatal myasthenia? So in our survey, we found 17 neonates had positive AChR antibody tests. That was about 3 children per year. So this is neonatal, presumably transferred from the mother. And we know, of course, that you can get neonatal myasthenia as a result of maternal transfer. We don't actually know how many of these children, these 17 neonates, had actual problems, because very often they test the baby even if the baby doesn't have problems. And we suspect it's really rather few, because I think as more and more of the mothers are being treated, probably the risk of neonatal myasthenia in the babies is actually becoming lower and lower. That's certainly our impression. But there is one other aspect of maternal antibodies, which is developmental abnormalities. So most myasthenia gravis patients have normal babies. Some babies are born with transient neonatal myasthenia, probably less than 10%. And in fact, only 12 newborn samples were referred for testing in 5 years, which is some other data that I happen to have. But very rarely, osteoglycosis may occur. And this was a condition I'd never even heard of until we were fortunate enough to come across a few of these very unfortunate women. So this is a baby born to a mother who'd had, at the time, 3 previous pregnancies affected with this condition. So the baby has fixed joints in the hand. You cannot open those hands. You can't bend or straighten the knees or the ankles. The chin is very weak, and in fact the baby had not developed breathing properly and died shortly after birth. Now this was because the mother hadn't had proper surveillance during pregnancy, because this should have been picked up long before. It's a condition which is caused by lack of fetal movement, and there are many known and unknown conditions, as you probably are aware of. Some of them are genetic disorders, and as in this case, it can be fatal quite often if it prevents breathing developing normally. It can, in some cases, be due to maternal antibodies, and those antibodies are specific for the fetal form of the acetylcholine receptor, so that they cross the placenta and paralyze the baby. There have only been a few cases studied, of which we were probably the only ones, but it is important to think about this diagnosis if you get babies with this condition. So just to show you 2 examples of maternal sera, which we've identified subsequently, here is a patient, a mother whose samples didn't bind at all to the adult form of the acetylcholine receptor, which is at the neuromuscular junction. But I think you can see here the red staining around the green cells when we express the fetal form of the acetylcholine receptor. So these antibodies were apparently completely specific for the fetal form of the receptor, and therefore causing the problems in the baby. And here is another mother who had antibodies to MuSK. And although there's not a fetal form of this, apparently these antibodies were sufficient to cause a developmental disorder in the baby, even though the mother herself was relatively mildly affected. So myasthenia in children, it's not common in many parts of the world, although probably a higher proportion of ocular myasthenia and childhood myasthenia in China and Japan, and perhaps elsewhere. We don't really know, we don't have enough data. High proportion of children without AChR or MuSK antibodies, which of course makes the diagnosis a bit more difficult. Spontaneous remissions may occur more commonly in children than they do in adults, and the role of thymectomy, which of course is used often in adults, is really not at all clear. And I'd just like to thank my colleagues who've been particularly involved, the paediatric neurologist from the John Radcliffe and Jeremy, who's now at Newcastle, and my colleagues in my own group and in neurology. Thank you.